thyroid. So swallow for me. I can use it either from the anterior or I can do a posterior examination of the thyroid. I am looking for any potential enlargement, looking for any swelling, looking for any difficulty swallowing. From here, I can then go on and do anything I want. All right, so let's say, oh, let me check shoulder strength. Push your shoulders up against my hand, relax, turn to your right, relax, turn to your left, relax. So what did I just test? Cranial nerve 11, but I also check not only the strength of the trap, but I see if you have any, and anytime I do this examination, I'm always going to tell the patient, is anything I do that causes you to have any pain or any type of discomfort, you let me know. So right up front, I'm telling them. I don't have to always ask, does that cause you pain? Does that cause you pain? Does that cause you pain? Let me know. Anything that I do causes you any pain or discomfort. So in addition to that, I also test the integrity of the SCM, trying to find out if there's any pain coming from that, especially if he had neck pain, did it reproduce any pain? Trap, when he contracts the trap, not only spinal accessory, but is that giving him any pain? I'd say, yeah, when I do that, that hurt right up in there. Okay? So if I wanted to, I can now continue. I'm going to do maybe my cervical spine examination. So here, I'm going to say turn to your right, and again turn to your left. Pick up the ceiling for me. Tuck your chin to your chest. Look straight ahead. Take this ear, try and touch your shoulder. Good. This ear, try and touch your shoulder. Any pain, discomfort with any of that? Nothing? Nothing at all? Okay. I'm going to press on the top of your head. Let me know if there's any pain or discomfort with that. Anything? Okay. I'm going to put it into extension. Pain or discomfort? On the left. Okay. On the left. Can you point to it where on the left? Okay. Right in there. If it's something abnormal, I'll try and make a note of it. If it's not abnormal, I know it's negative. I'm not going to jot it down. I'm not going to waste my time. I know now it's normal. And I write up my report. Oh, that was normal. That was normal. That was normal. Oh, this was cervical compression, left lateral bending, pain at C2. Do you have any pain going down into your arm or shoulder? Immunized radiation. So that's all the test is for. Test is compression, checks for radiculopathy. Not positive for radiculopathy, positive only for steady rotation. So I do the same thing on the other side. Any discomfort?
Maybe a little discomfort, a
Maybe a little bit. Same thing happens. Next is test.
Shoulder depression.
Shoulder depression, pain or discomfort. Pain or discomfort.
Feels good.
Good. Push back against my hand, and I'll have checked the integrity of the extensor muscles. Hold it for about 5 seconds, any pain or discomfort. Push into my hand, and forward, your head, try and touch your chin to the chest. Hold it for again 5 seconds, any pain or discomfort. Okay, let it relax. We already checked cervical, we can check lateral bend to the right side. Relax, bend to the left side. Relax. So we just did orthopedic testing for the cervical spine. We did lymph node examination. We did thyroid examination. While I'm doing all of this, I know cranial nerves pretty much intact. He can talk to me. Doesn't have any abnormal facial features. I'm watching his eyes and as they move, but we're going to go back and check him anyway. Now we'll finish up some of the cervical spine and brachial plexus. So we'll check strength bicep, pull to your shoulder. Check it, 5 seconds or so, let it relax, any pain or discomfort. Okay. Again, same thing, pain and discomfort, relax. I'm going to push this way, you push out against me. And again, stabilize it so you're really isolating the muscle. You're not pulling in, let's say, your shoulder or his body. You just want to get the muscle that you're trying to test. Push and relax. C6, right? We've done C5. C6, C6, C7 is this, right? So, wrist flexors, finger extensors. We're going to do the same thing. Just there, hold it like this, push up against me. What other test am I doing?
Cousins?
Cousins test, right? So if they had elbow pain, I'm going to know. We've just done an orthopedic test for his wrists also. We're going to do wrist flexion. Hold it. Hold it. Turn your hands over. This way. Press my fingers. Pull. Fingers straight out. Pull. Push up. Try and squeeze my finger. Open. squeeze my finger, squeeze my finger. Try and separate your fingers. I'm just going to try and squeeze them. Any pain or discomfort with any of this? Another test I like to do is just called the opponent's test, thumb to pinky. So you ask them to bring their pinky together. You try and separate it very strong, no problem. Same thing, nice and strong. You can do that with each finger if you wanted to. Okay, just to check muscle integrity. Next, if I have my reflex hammer, what I would do is bicep reflex, just to get them to relax. Let it drop there, and you check, gee, that's reflex. Same thing here, check. Tricep, get the arm to drop, check. Check. Brachioradialis, just let it drop, check. And brachioradialis, just let it go, check. And I can do Hoffman's, relax. Okay, same thing. Well, I still have my reflex hammer nearby, patient seated. Check. Check. Achilles. The only thing I need to do left with my reflex hammer would be Babinski. If the patient was properly gowned and didn't have their shoes and socks on, would just come, do my Babinski. Babinski, plantar reflex, like we did today in the room with the patient. Plantar reflex basically is a withdrawal reflex. Just take the end of your reflex hammer, just hit the patient's bottom of the foot. Basically, they're going to pull away. Okay, it's just a normal reflex response. Another type of reflex, nothing to indicate abnormality except if they can't do it. So now I've just checked a couple of pathological reflexes. I've done my upper extremity, lower extremity reflexes. While the patient is still here, I can say, push up against my hand, push up against my hand, push out against my hand, push out against my hand, pull back, pull back. And I probably, when they were standing, do a heel walk, toe walk, inversion, eversion, or I can do the same thing seated. Push up, hold it, push up, hold it. And again, if there was a specific problem somewhere, if they had weakness in an upper extremity, lower extremity, I would do a little bit more detailed testing. So let's say their shoulder was weak, they felt it was weak. So while I was checking the integrity motor-wise from brachial plexus, I might also do a test. Let that come down, bring this arm down, push this arm up against me. Push, 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 go, 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 let it relax. Push again. Go, 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 go. I might do that 4 or 5 different times to see if fatigues or reproduces any pain. And again, these are not taking long to do. Well, they're still here if they had shoulder pain, or even if they didn't, because just anybody can have shoulder pain at any time. You see many patients with shoulder pain. So what can I do? Well, I already checked this bicep muscle here. I checked against resistance, didn't reproduce any pain. You can do other tests. You have your speed test, hands straight out. Push up against my hand. Good. Bring the thumb up like that, make a fist. Like that. Hold it. Good. Turn your thumb down. Good. So we just did 3 tests for right bicep, supraspinatus. Same thing here. Hold it. Fist. Thumb up. Down. Good. So we can do Hawkins Kennedy. Up, over. Push down against my hand. Push up. Do that on both sides. Well, I have the patient here. If I had the patient supine, I might even do some other tests, some internal and external rotation of the shoulder. Again, just to see if there's any pain, any dysfunction in the shoulder. If we did suspect the rotator cuff tendinopathy, Christina, where'd she go?
Hi.
Hi, what other tests would we do?
We could do the horn blowers, and we could do
Horn blowers 1. What's that for?
horn blowers
Teres minor.
Teres, good.
And then we could do the lift off test or the belly press test.
Belly press
Subscap.
test. To the subscap here, push against my hand, push out. Good. And the last one,
Lift off.
lift off. How do you do that?
Place your back of your hand on the nape of your back,
Right.
and then you're gonna be.
And then try and
you're
push your
trying to
hand
pull
out.
in as you
Yeah. And that's for
pull. Subscap.
subscap. And then what test is for infraspinatus?
Resisted horizontal abduction.
Or this, first one is the eye, make it up.
Great. Check against
Mhm.
resistance. Good. So we did a whole bunch of tests for the shoulder. It took just a matter of a minute. It doesn't take long when we do a lot of these. Well, I still have this patient here. You can do a couple of other tests. Bring this leg out straight. Any pain, discomfort coming down the leg, anything in your back. Bring this leg out straight. Any pain, discomfort in your back. Bring that down. Bring both legs up and let them come down. Okay, good. Next, I would do my cranial nerve examination. So I would check cranial nerve 1, you checking the sense of smell. Many patients, COVID, they do lose smell. Some patients with certain disorders, like this patient that he has with Parkinson's, do lose the sense of smell. So you should test it. It should be part of your normal exam. You will not know the result of something without testing it. And I'll say this, if it's on your exam sheet, you should do it. Wait, your exam sheet maybe sometimes shouldn't be so extensive, like include every single orthopedic test in the world, because when you do, or if you ever get called into court, an attorney will use it against you. So, well, doctor, you have all these tests on this sheet, how come you didn't do them? Are you thorough in your exam? Well, no, I didn't do them. Well, why not? If they're on your sheet, why didn't you do them? Don't you think you should have done it to rule out some of best if you're going to do something, regional examinations for shoulder or something like that. Or, when I was in practice, I didn't use anything other than a blank sheet of paper. Here's my paper, these are the tests I did, and that was it. So I didn't have, again, it was nice to know these tested, or did I miss something? But once you're getting into your routine and you know what test you need to use and tests that you know should be very specific, those are the tests you want to always be going to. If there are additional tests, then you can add them on as you go along. So cranial nerve, you do cranial nerve 1. Ophthalmoscopic examination. I strongly suggest that you look at, stand for 25. I took your ophthalmoscope today. The first thing I looked at was the setting. You know what the green and red numbers mean?
No idea.
No idea. I didn't think anybody has any idea what they're for. Those are your diopters. If you have corrected vision, if I took my glasses off and wanted to look in there, I have to use that to correct my vision. With this, I just go back to 0. So now it's corrected for my vision. So now I can look more clearly into the patient's eye. But if I had it on a +3 or a -3, it would have been totally blurry.
Last semester, Dr. He told us that we would do it to correct the patient as
You
well.
do both.
Okay.
But yes, and if they have an abnormal vision and you have normal, it may need to be corrected somewhere.
Okay.
But even as you go into the eye, you can change those
Okay.
diopter settings because you'll be able to see deeper and deeper and deeper.
Okay.
And that's the whole idea with the ophthalmoscope. You're going to start here, right eye, right hand, you open the eye, tell the patient to look across at something. First thing you're going to get, red reflex. The panoptic, if you have it, it's a great tool to use. It makes looking into the eye incredibly easy instead of just a little, ophthalmic top that you have on it. And you get it, you look in. As you come in, again, you're looking at different levels of the eye as you go in. Then you're going to be real close, almost face to face. You begin to see the optic disc. You're going to look at the shape of the optic disc. Is it smooth? Is it bulging? Patient who has head trauma, a potential brain tumor, you'll see bulging of that optic disc. Patient who has severe headaches, dizziness, you go, oh my God, they might have a tumor. You better check their eyes. Patients who've had prolonged and severe diabetes, you better check their eyes. Do they have cotton wool appearances? So you check the fovea, you check the optic cup, the optic disc, and you look at the ratio from the disc to the cup, and you're looking at vessels. So you should have arteries, veins, which are larger. Veins in the eye are usually larger. Arteries are smaller. You can have nicking and pumping, meaning vessels and arteries may go over each other. But again, learn how to use that ophthalmoscope and you look into the patient's eye, deep into the eye. Look at Stanford 25. It's a 10 or 12 minute video. The guy does a great job on the ophthalmoscope. Incredible job. It's really good teachers.
What did you say
that?
that other piece was?
Just the ophthalmoscope. You have now the panoptic, it just has a bigger thing on the front.
Yeah.
You can see much more better with that as compared to just a small, kind of rectangular top, which
Yeah.
I was trained on. It made it hard to use, but you have to be good at it.
Yeah.
So while you still got this ophthalmoscope, you take the ophthalmoscopic head off, and you can now do your ear examination, do your otoscopic examination. So again, right ear, right hand, you examine the ear, pain or discomfort, pull, any pain or discomfort. Then you're just going to lift the ear, you straighten out the canal, come in, and hold it. So what you want to avoid is holding the otoscope where you have to push down on it. You want to keep it level, so just keep your hand under it, keep it level. You can try like this, but it needs to be kept level. And then you look to see the tympanic membrane. And it should have this pearly look appearance to it. Should be no bulging of it, should be no breaks in it, and your otoscopic exam is now done. With the ophthalmoscope, if you still have it, you have a light on it that you can use, where you take your pen light, begin the examination of the eye now for 3, 4, and 6. And we'll give you these as little points of reference for 3, 4, and 6. So this also, on the front side of this where it says pearls, pupillary size is determined by the parasympathetic nervous system. Probably the most important cranial nerve for the eye is 3. I think it innervates 4 out of the 6 muscles. And sometimes what it also explains here is the tract. So sometimes people go, we can affect the eyes by adjusting the spine. And again, I was trained in some of this. I did complete the chiropractic neurology diploma program, and this is things we were hearing. But this is a possible, if you read this, mechanism to understand the parasympathetics and if patients have nystagmus. What is the more dangerous type of nystagmus? Vertical type nystagmus, right? That could indicate even a central lesion. The horizontal nystagmus or even rotary nystagmus usually means a more peripheral type of disorder. But here it goes through the tracts that work. And even when we examine the nervous system, you should understand and know all your tracts. I didn't even go into sensation yet. Let's jump to there real quick. What tract carries sensation? Sensation.
I would just say
Okay, and what else? Anterior lateral spinal tract. And the anterior is for what? Pain and
temperature.
pain and temperature. Lateral spinal thalamic for touch. Dorsal column.
You should be talking.
Joint position. Good. So all 3 of these tracks
should all know
be
it.
tested. There's different things you're testing. Which again, I go in the room, you do temperature, you do temperature, hot, cold? No, well, that's an important track. That's your anterior, spinal thalamic tract. These are tracks that are going up to the cord. What track comes down? You test. Cortical spinal. And when you test reflexes, what kind of a reflex is it sometimes called? Deep tendon, but what else? It's a simple reflex.
Muscle stretch.
Muscle stretch, but it's just a simple reflex. It's one thing happens. Monosynaptic, there you go. It's a monosynaptic reflex. Strike follows a track up to the level of the cord. It synapses at the level of the cord and straight up to the brain, to the motor cortex. And you get a response. Okay? But in the eye, here in the eye, the parasympathetic nervous system constricts the pupil and it arrives at the eye via the cranial nerve 3. The sympathetics reaches the dilated pupillae muscle in the anterior part of the eye via a complicated route. The preganglionic sympathetic fibers exit the thoracic spinal cord via a ventral root at the level of T1. Then they ascend to the cervical chain. They synapse in the superior cervical ganglion with postganglionic neurons Then they travel along the carotid artery as the carotid sympathetic plexus, and finally reach the dilator muscle in the eye with the long ciliary nerves and the nasociliary nerves. And you remember that the ophthalmic nerve be one branch of cranial nerve 5 also. That's what people will sometimes say, oh, if you can adjust the upper thoracics, you affect the cervical sympathetic ganglion. And there's a proposed mechanism for that. We're thinking chiropractic, well, why would this potentially work? And this is the mechanism that's usually discussed. This is right out of your clinic manual book, in case you didn't know it. This is also the clinic manual book.
Yes. My clinic manual book.
Just
Ah,
examination of the eye.
keep it on my nightstand.
Okay, each of the muscles and cranial nerves involved. So, important piece of paper. So, we're going to examine the eyes real quick.
Yeah.
I know this is taking long, but there's a lot to cover. And usually this exam can be done in less than a half hour, if you're not talking to it.
Love that.
We have our pen light. First thing we're going to do is check our H reflex or H pattern. We ask the patient, just follow this. And we're going to look at the eye and go slow. Don't rush them through it. You did. If we knew we had a problem there, sometimes what I would do is the patient would cover one eye, just cover the eye. And I might examine just one side just to make sure we have no other issues potentially going on. Okay, so we've checked our H pattern. We've now checked cranial nerves 3, 4, and 6. Then we're going to check accommodation and convergence. Again, we'll ask the patient to look at the top. We'll bring it in slow. They should converge. And then just bring it back out and see if they can refocus and the eyes separate. We've had about 3 or 4 patients here in this clinic that when we do accommodation and convergence and bringing this in, an eye might go and look medially and nasally and then suddenly break out. So there was a weakness somewhere with the cranial nerves, possible medial rectus, where again, we're bringing this in, they bring it, and all of a sudden, this quick lateral deviation away from it. It's not an nystagmus, but just a quick deviation from it. So again, what does that finding mean? Is there something central? Maybe we get them out to an ophthalmologist and have a more thorough examination being done. Next, we're going to check pupillary response.
Jump the
How do you
gun.
like to do this? There are a lot of ways to do it. That's one way. Again, you darken the room. You can come from the side, looking at both eyes. And all you need to do is just don't cross over the nose. That pupil reacts on this side, and I can check the same thing, and it's reacting on this side. If I do this, you're coming too far over, and I'm going to get light into that eye. You can just do this. Same thing here. If you want to put the hand up, that's fine. I'll have no light shining into that eye from here. So we have that done. Next, I have my pen light. I can even use my ophthalmoscope. I can examine the mouth. When you examine the mouth, you have to protrude the tongue. You have your ostick. Right? You look to see if the uvula elevates, not deviate to one side. There are a lot of different findings related to that if it does deviate and what it can mean. But when you examine the mouth, you also have to do a lot more that I know people don't do. So you're looking at, open the teeth, are any teeth missing? You're looking at sides of the mouth, is there a nice red color? You're looking at the throat, make sure the tonsils are not enlarged, make sure there's no enlarged vessels around the tonsils, especially if they've been complaining of sore throat, or if they have, past history of seasonal allergies, and it's really been bothering them, they have a scratchy throat, you may see some dilation of vessels there. Okay, it's not unusual, but it's not just looking at, it's examination of the mouth. That means teeth, that means the skin, that means glands that drain from there, okay? And looking to see if there's any other spots in there. types of infection. There's one that is the complex spots. You know the complex spots that you're studying for part 3. Complex.
Yeah.
Guess?
What disease associated with that?
Measles? I think it is.
I think you're right.
Oh yes, the
Important to
measles.
know. Simple physical exam finder. So we've examined 9, 10, we've examined 11, what else are we missing? We missed something, 3, 4, 6. Oh, yeah, we missed quite a few. Now we got our pinprick light touch. Okay, we can do now the whole upper and lower extremity. We can start here and check cranial nerve 5. First, we can do sensation with pin, sharp, dull. Again, we'll explain to the patient, this is sharp, this is dull. Tell me when you feel it sharp, tell me when you feel dull. And again, just ophthalmic division. CN1, CN5, 1, 2, 3. 1, 2, 3. Sharp and dull, and then again, light touch, cotton swab, bring it out, and just stroke. Stroke, 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 stroke. Is there a reflex on the face?
Jaw jerk, corneal.
We got corneal. This, as well as your corneal reflex. Poke them in the eye. We were taught in school, we had to do it as part of the physical exam, where you took a long Q-tip swab, you had to roll the eyelid up and look behind the eyelid. That's cruel. That's not cruel. It just feels fun. It's not painful at all. But yeah, we just have to do that. We have to examine the eye a bit thoroughly. So if this patient, let's say if they had liver disease, what might we see in the eye? Jaundice. And the best way to see it?
Rub it.
Lights off, I don't know.
That's up there,
Natural
right?
daylight. Bring them by the window. Take a look at it. If you think they have a little, if you get it at natural daylight, it could be a lot that's there. In addition to having maybe jaundice in the eyes, if it's a really severe liver or gallbladder problem, an obstruction, it's going to start to show up in their skin. It's going to turn yellowish. If it's really, really, really bad, they're going to be oozing, almost like wax from the head.
Hot.
Yeah.
That's hot.
So, we did cranial nerve 5, we said there are reflexes, there's sensation, and then we do cranial nerve 7, and that is just making faces, smile, pucker the lips, frown the eyebrows, open the eyes, close the eyes. We can check to see if they can keep them closed, close it. Okay. And then we can check the integrity of the tongue, push, push. If we still have our tongue depressor, stick, put it up and say push against stick, and see if they have strength in the tongue. It's coming out straight forward. So there we have cranial nerve examination is done. If we still have our pin or we want to change it, we can now do the whole upper extremity. 5, 6, 7, T1, 5, 6, 7, T1. If you're in a gown, 2, 3, 4, 5, S1, sharp dull, sharp dull, sharp dull. It's done. Tuning fork, you're going to finish up your sensation along with your Weber and Rhine test. 128, was it 516, 518 for Weber and Rhine? 512. Sometimes the 512 is not the most effective. I don't know why. I find that it never really works. I use the 128 or the 256. 256 we did earlier today. Worked on that patient, but just give a simple strike against your hand. You don't have to be banging it where you hear bing. It's like up and down the hallway. Bing, bing, bing. Like church bells. So just a little strike, put it on the top of the head, explain to the patient what they're going to feel, either a vibration or sound, and where do they feel it, one side, either side, or both sides. And keep it on there, let them feel it. They feel it, okay, once it stops, you can squeeze it, stop, it stops, okay? So the Weber test. And then do your Rhine test. I know you taught in school, if that's not positive, you don't have to do it. No, you should still do it. Because the Rhine test is checking for something else also. You know, it's air and bone conduction. So it is a little bit different of a test. You're checking actual air conduction. So you have, again, your Rhine test, you strike it, find a mastoid. Don't just go on the tip, really just go behind the ear, right on that mastoid process. Not just this very bottom part here, but right on it. Put it there, tell the patient again, you're gonna feel a vibration, a sound, let me know when it stops, and you count. You say it stops, take it right outside the ear, count again, and normal should be what?
Double.
2 to 1 what?
Air to
conduction greater than
bone.
bone conduction. So if it's not 2 to 1, guess what that means?
Means
That's
some
wrong.
sort of-
It means, yeah, if you didn't do the test, you may not know that they have a potential loss of some air conduction. The air is picking up sound, and it's not picking up at a 2 to 1 normal ratio. And then if you have your tuning fork, you get your next tuning fork to do sensation, vibration sense, for upper and lower extremity. And again, that should be done on an actual bony prominence, so either knuckles, tip of the finger, you can do it, it's gonna be very hard, or at least the second or the mid metatarsal or the phalangeal joint, carpal. And just press on it, don't press hard, they should feel a vibration. Again, you don't put it here because you don't wanna be pressing hard on that, because now you're checking also pressure receptors. Same thing when you're doing joint position sense, so put it over. If they don't feel it, just go up to a next highest bony prominence, try the elbow, see if they feel it. Patients with diabetes, they may lose vibration sense. Patients with dorsal column tract problems may lose vibration sense. Vibration sense in diabetes is sometimes the first sense to go. Those are the patients, my grandmother always goes put her hand in the burning hot water. It's probably because she had diabetes and wasn't feeling anything, but. So that goes, same thing in the lower extremity, medial or lateral malleolus, put your tuning fork on, or if you can put it onto the front part of the big toe, you don't have to do that. If you feel nothing there, just like this morning when we did it, we just went onto the tibia and checked that to see at what point you begin to feel it. Doesn't work there, go to the patella, see what happens. So just work your way back on up. So we've done a lot so far. We've done all of our tracks. We've even checked for some nerve root tension signs because we had them lift their legs up. If they had shooting, radiating pain, and we would know that. We can even do a slumps test in this position now. So we would ask the patient, just pretend like you're sitting in a chair, but kind of slumping, let your head come down. Just slump over a little bit, and then just bring this right leg up. Let me know if there's any pain or discomfort. Okay, bring it down. Same thing on this side, and bring it down, and relax. Now you've done your slump test. Regular patient says, I've got shooting pain coming down my leg. You've just been a long track line. You put some nerve tension on that. Again, do it first without it, and then add more of that nerve tension, and that's what the slump test actually is. It is a nerve root tension sign. And on the handout, I think I gave you yesterday, it's also a great flossing technique. So you can put the patient, have them just do, if they're having entrapment of some kind, you just have them sit and they do this. Or they can say, gee, do this and bring it down. Does that make it worse? Or they can bring their head back and they can alleviate some pain or discomfort while they're doing it. So it is the same thing with the upper extremity nerve root tension signs, which we won't go that much into today. Those though should be done really supine when you do those, so you can better control the arm and the hand. You actually do it in different stages. First here, then with the arm, then with the wrist. So you do it step by step by step, and then lateral bending away to see if you recreate that nerve root tension. Okay, so now still seated. We still have our stethoscope. We put it on, we do all of our auscultation. Did we miss anything yet? Yeah, we missed nothing. We have our stethoscope. First thing, we're going to listen to carotids. The bell primarily, you can also listen to it with the diaphragm, but your carotid arteries. Then you're going to listen to either heart or lung. We can start in the posterior, and your lung sounds you're going to listen to again with the diaphragm and bell. You're going to listen to just above the scapula, and you're going to come down to the interscapular area, comparing side to side, 2 or 3 areas. Below the angle of the scapula, a little bit wider coming out, and then in the periphery of the lung fields in the mid-axillary area. So the big question is, why do we do that? And then you go same thing on the anterior chest. Again, you're going to auscultate the neck, then you're going to come down parasternally, side to side, into the midclavicular area you're going to listen to, midclavicular area, and then again interlateral part of the chest wall. What do we do?
Case you just gave us.
Do it for the case.
Yeah.
But you're auscultating now, maybe there's no reason. What's the anatomy? Well, what's the anatomy? The anatomy is when we put our stethoscope here, we have tracheal breath sounds. Okay, very harsh sounds, harsh sounds, loud. Then we come down a little lower to parasternal. What do we have? Bronchial sounds. Okay. We move out to the periphery. What do we have? Bronchovesicular, midclavicular. And then we move all the way out to the lateral lung field. What do we have? Vesicular lung sound. So as you learned all that anatomy, and those airways come down and move further out and out and out and out, you pick up the sounds in each of those areas of the lung fields. And you ask the patient to take in a deep breath and blow out through the mouth. If you need to, stop it just for a few seconds so they don't hyperventilate and pass out on you. Okay? That could happen. But you're listening, and again, the tracheal sounds are very, very loud and harsh. Inspiration and expiration are about the same. You listen to bronchial sounds, again, they're kind of harsh and loud, and again, inspiration, expiration are about the same. Bronchovesicular sounds a little bit quieter. Inspiration shorter than expiration. Vesicular sounds, basically inspiration, expiration is longer than inspiration. Very quiet type sound unless there's some fluid accumulation there. Okay, so it's simple to do, but again, know what you're listening for, know what kind of sounds you're listening for. Don't just go there, you know, and you say normal, you know, especially if presented to me, and a patient has a 50-pack year history of smoking, I'm going to say, what? One field's really normal, smoking how many cigarettes over the last 50 years? I don't think so. It's got to be something there. It's got to be some kind of a crackle or a wheeze there. And you'll, again, you hear it and know it's normal, you'll hear the wheeze, just that, you know, kids, you can especially hear it, and if you don't want to hear striders and things like that, or lung drivers, harsh sounds, but you can definitely hear them. Heart sounds, fairly simple to do. Again, screening, I know you're toward a detailed examination. It's good to know that, because if you have to do a more detailed, but the patient doesn't have a history of any heart disease, aortic, pulmonic, tricuspid, mitral. So inch your way around the heart from the aortic, pulmonic, listen, inch your way down, tricuspid, Erb's point, tricuspid, and then to the lateral wall to mitral. Simple. And again, just hearing that normal. Hear something abnormal, you'll pick it up. Okay, certain times you may hear, especially in children, what are called innocent murmurs. When the heart's not fully developed, normal to have these kinds of innocent murmurs. If you do hear something, send them out to the pediatrician. Okay? Periphery, you also have all your tests for vessels, feeling the brachial artery, the radial ulnar artery, brachial artery, radial ulnar artery. Feeling best if you're going to do pulse rate, just listen to feel the carotid. Check your carotids too. Okay? Just don't do it bilateral, right? How come? The only time I would do that would be what?
Choke somebody out.
Huh?
What do you say? Double cry?
Double.
Yeah, the patient's annoying.
WWE.
You didn't like
If you
them.
wanted an
What?
audit.
Yeah.
You didn't like them.
No, if you have really, really severe tachycardia,
Really?
do a carotid sinus massage, and it's a quick way to. That used to be a treatment. So we just checked our pulses. We get the patients supine, and we do abdominal exam, we check their lower extremity pulses. So now we've done eyes, ears, nose, throat, heart, lung. We've done our brachial plexus. We've pretty much done most of our lumbar plexus as far as reflexes and sensation. We We've done some pathological reflexes. We've looked into the eyes, nose, and throat, ears. We've examined. Oh, diaphragmatic. Oh, we can do chest expansion. This is always a board question. Chest expansion. I'm not sure how they're teaching you now, so I would just go by that. But the way I was taught is you find that spine is processed at about the level of the inferior angle of the scapula. Have them take in a deep breath, and you look to see how much separation of the thumb that you have. Or you can just put tape around the patient, check the normal position, chest, normal breathing. Have them take in a deep breath and just see how much of a increase in chest expansion they have. Pretty much, we did a lot of the exams seated. So now we'll put the patient supine.
41 minutes of great.
Again, if you needed to, if you want to practice things, you can do in this position, Linder's test, or fracture. Stability, fracture, what else? What else? Meningitis, what are you looking for?
Electric shock
What's it
pain.
called?
Lormeets.
VMS, Lormeets, right? You can do Linder's, you can do Sotal Hall with stabilization. Yeah, next semester when you guys start doing your CAWs, my recommendation is you have to do 2 CAW presentations, one on a therapy, one on some kind of a test. Look at these orthopedic tests, see how good they really are. These tests for meningitis, it's like flipping, worse than flipping a coin. You do it on a patient and you get a negative test, and that patient has meningitis, you're in big trouble. And especially if they're coming in and their symptoms are, feeling like tight and just kind of hard, and they're complaining of nuchal rigidity, and you feel that stiffness there, and they have enlarged lymph nodes, and they have, their temperature elevated, and you don't take their temperature, but it's elevated, and they feel hot to your touch, out the door. Because doing these tests could be negative. You got nothing wrong with you, not meningitis. Tests are not reliable. Those 2 tests, they were done right at it. No, wait. Yeah, Yale. They're actually done. Kernig's test, all of these tests just were not useful. So the presentation of the patient is the most important thing that you'll depend on. You get the patient sent out and let them work it out, okay? And you can see it, again, you see a lot coming into your office? No. You have a patient who comes in routinely who suddenly is not feeling well, that may have been exposed to maybe an outbreak of meningitis? Sure can. Sure can. They may just be coming in because they're not feeling well, the back or neck is still hurt, especially their neck, and they don't really know. They may not have even thought of taking their temperature. They might be feeling run down. Oh yeah, I've been doing a lot of activity, fixing up the house, working in the yard, overworking. Take the temperature, examine them, and see if they have meningitis. Okay, in this position, again, orthopedically, pretty much done too for the cervical spine. So we're going to examine the abdomen, have the patient bend the knees, feet flat, have them expose the abdomen, and again, you can use a towel, you can use appropriate towel dressing for the patient. And you inspect, is it protruded, is it distended, is it flat, is it indwelling, lumps, bumps, bruises, discolorations, normal inspection. Then your stethoscope, you're going to listen to your 4 quadrants. And again, just for about 10-15 seconds in each quadrant, listening for, again, any abnormal sounds. The biggest abnormal sound, the worst abnormal sound you could hear is what? Nothing, yeah, silent abdomen. That's pretty bad, okay? But then also, what else you want to listen for? What about it? You want to listen for bruise, right, over the abdominal aorta and over the
People keep saying that word and I still don't know what the fuck it is.
Have you ever heard an abdominal bruit?
No.
Never heard of bruit?
No.
Take blood pressure?
Yeah.
You've heard of bruit. bruit is blood kind of rumbling through a vessel.
Ah.
The vessel begins to close down when you have
Waiting for
calcification
this.
there, so instead of it being nice and open and flowing through nice and smoothly, it begins to close down, you have some roughened edges, so as the blood comes through, take blood pressure, what are you doing? You mechanically compress that brachial artery, shut down, right? And you begin to open it up very, very easily, slowly. What begins to happen? Blood begins to go through a very narrow vessel, and just like a bruit, whether it's in the neck or in the abdomen, it rumbles through there. You begin to open it up further, and then the sound, what happens?
Repeats.
Disappears, right? It's your diastolic pressure, the blood's flowing right through there, nice and smooth, no more occlusion there. So that's somewhat of a bruit, what a bruit might sound like. But it's just somewhat of an explanation. You'll hear kind of that rumbling sound of the fluids go through this constricted area, okay? So you listen for any abdominal sounds, bruits over the abdominal aorta, looking also for any pulsations in the abdominal aorta. And then you begin your palpation. You first start with superficial, let one hand rest, your upper hand, let that press into it. Don't use this hand to press so much, because then you lose things that you're feeling for. And just little circular motions, feeling for any enlargement, discomfort. Down into the right lower quadrant, you can feel for the vessel, femoral artery, you're feeling for any lumps or bumps or distension. Work your way around the abdomen, any pain or discomfort, just feeling along the colon. Ticklish. And then from either side, you can palpate the liver. You can either come in with your fingers, you can use your thumb. And what's that sign if they jump? Like these four.
Just large hepatomegaly.
The first letter, what is it?
Hepatomegaly? No.
What else is there besides liver?
Gallbladder, cholecystitis.
Or you can use the hook technique for the gallbladder and liver, and again, taking a deep breath, blow it out. And you lift your fingers in and around, you can feel
Really
the
yank
edge
up.
of the liver. If the liver comes down too far, you'll definitely feel it if it's enlarged, or you're looking to feeling hardened nodules. Percussion of the abdomen, what sound?
Dom.
Mixed resonance, right?
Dom.
And dom.
Guaranteed it'll be a board question. Timpani, tympanic.
You guys are ready this week. You're gonna crush it.
Oh, wait.
We have tympani, and if we go over the liver,
Dullness.
dull. Definite change, right?
Got that question right.
Dull,
Yeah.
tympanitic. Lung, we could have done this seated too.
Resonant.
Resonant.
2 for 3, baby.
Like that.
That's Hall of Fame status, man.
I'm done. I'm good.
Diaphragmatic excursion.
Sure. Throw that in there.
Is that a sound you're asking for?
Not a sound. What is it?
How much does the
Oh, how much does chest
area
expand?
or the diaphragm move?
Yeah, that's right.
Diaphragmatic excursion. It is somewhat important to know, because it can happen. Just like our patient in the case. So you percuss from the chest, you have resonance, reach the superior border of the liver, changes to dull. Mark it, right? Have the patient take in a deep breath and hold it. What happens to the diaphragm? Pushes down, right? So you read percuss, and here was the first mark, and it should come more downward. So now it might be, it comes down to here. So the liver was pushed down as you have diaphragmatic excursion, meaning taking a deep breath, diaphragm pushes down, further pushes down liver and gallbladder, and you should be about 3 to 5 centimeters. Excursion. If If it doesn't move, what could it mean?
Damage to the fracture.
Damage to the phrenic nerve. You have diaphragmatic bulging, what it's called, is damage to the phrenic nerve. You can sometimes see that with severe car accidents. Hurt themselves, severe whiplash, damage to potentially phrenic nerve on one side. And they go, oh, I'm having some, can't breathe, can't take in a deep breath, and they lose that diaphragmatic excursion and ability to take in a deep breath on that side. So this could be out there, could be present, could be, finding you might not see it after initial car accident, but follow-up, that might be a problem if you pick up damage to the phrenic nerve. Abdominal exam, we did liver, we did gallbladder, spleen. Again, palpation of the spleen, should you normally feel it? Again, if there's infection of some kind, leukemia, we have splenomegaly, hepatic splenomegaly, a lot that you can feel the inferior part of the liver, sometimes depending upon how skinny the patient might be, but you could feel that, especially if you get them doing a diaphragmatic excursion where it is pushing down into your hand. You might be able to feel the edge, the lower edge of that liver. In this position, anything else visceral wise that we need?
Kidneys? Palpate kidneys or no?
Palpate kidneys, it's a dual method, just come underneath the flank. Hand comes in, roll. Which kidney is lower?
Right.
Right, sure.
Left.
Left.
Right, definitely. Right.
Right. Left.
Taking part 3? She knows the answer, right?
Part 2.
Part 2.
Oh, then don't worry about it.
Yeah.
I got a lot of questions.
Yeah.
How many lobes on the right side of the lung?
Trick question.
I would say that.
You got the heart on the left.
3? How much on the left?
2.
2, upper and lower. Left, how many? Right, how many?
3.
3, upper, middle, lower. Let's see what else we have. Throw a question. The pleural friction rub, what is it?
No, not pleurisy.
Well, it's kind of what's called pleurisy, but yeah. Pleurisy is not really a diagnosis, it's a secondary diagnosis. It results from something else. What is pleural friction rub?
Fluid outside of the lung, compressing the lung. No. You seemed to like it before I said that last part. Fluid outside of the lung. In the
Pleural
viscera.
friction rub is you have fluid
Plural.
in the pleural space.
That's
Thank you.
It's inflamed,
Yeah.
it's swollen, and the patient takes in a deep breath, and they can't do it. They get pain over that area. But the pleural friction rub is when you're auscultating, as they do that, you can hear kind of like this leathery sound. If you sometimes describe you're out walking on snow, it crackles under your foot.
Yeah, take a
You have
jacket, just
pleural
rub it
friction
together.
rub. Patient just can't do it. So there's an infection there of some kind, or some kind of definite pulmonary abnormality that hurts to do. Pleural friction rub would be the auscultatory finding at that present. Yes.
Do you think that that's what was going on with that patient, Greg?
Greg? Oh. Why? What was he having?
Remember? He had that
Difficulty breathing?
intercostal pain.
Could have been also from, I don't know what.
Just say.
Could have been from his 10 marijuana cigarettes he smokes a day.
You know.
He was a character. He'll be back. Somebody, you'll see him, definitely.
No.
Right? Christina is hoping.
What's the last name?
I will find the victim to dump him on.
First time he came back into the clinic after
I think
about
me and Dave
a
are-
2-year hiatus.
Yeah, I think we're good for this semester.
What's that?
Oh,
I think we're good.
Okay, anything else on the abdominal exam? Supine examination, there's a lot of other things we can do.
Yes, and a
You
lot
do
of
special
there
tests, you can do what kinds of special tests? SOAS test,
Obturator.
SOAS test, obturated test. And again, how good are these to rule in and rule out appendicitis?
Horrible.
And yet we still do that.
Horrible. Very bored.
Still trying to figure
What would
that
be
part
your
out.
best test for a suspected appendicitis?
punch him in the gut.
Get them the hell out of your office.
Presentation, history.
Yeah.
What's the history?
I just started feeling
Usually
pain out of
typical-
nowhere.
Typical, no, typical, again, this is why you asked the question. Where did the pain start? Where is it now? Okay? Because in appendicitis, the typical presentation for that, kind of like 8-year-old up to 35-year-old, in that age group, or it's a typical presentation. Below 8, atypical. Above 35, atypical. Usually it starts with periumbilical pain, just getting pain around the belly button. And usually the preferred pain from the abdomen, small intestine, is usually periumbilical pain.
You could be pregnant.
Then what begins to happen, it begins to travel to that right lower quadrant. No more periumbilical. So it's here, starts here, then 2 or 3 days, it goes to the right lower quadrant, kind of doubled up in pain. You have guarding of the abdomen, rigid. They'll do sometimes to protect it, they're gonna walk over, they're gonna put their hand across it, okay? They're protecting that abdomen. It's just a normal reflexogenic response. The abdomen becomes hard. And they develop a fever. So you can palpate in there, and you can do your rebound tenderness, do they have any?
Don't forget the tickle one.
Rebound tenderness, do they get any pain reproduced to the right lower quadrant? May or may not have it.
Hypoesthesia.
But ultimately, they're gonna run some labs, CBC, it's gonna be highly elevated, your white blood cell count, will do an ultrasound of the abdomen, and you have appendicitis, and hopefully it didn't rupture.
I don't want you doing all those ridiculous tests.
Abdomen, potential for peritonitis and infection throughout the abdomen. So again, it's not something patient presents, don't worry about it, just a little constipation or something. No, you don't usually get periumbilical pain with constipation. If you get constipation, usually where is it? Which part of that digestive system? Yeah, usually large intestine. The large intestine refers right along the area of the large intestine in the bowel. This is its referral site. How do visceral organs refer? Are they directly innervated?
Oh, how did it refer?
Yeah. What makes you get, not just, let's say, liver, say you have some enlargement of the liver, but it's not pressing on the diaphragm. But what causes that referred pain from an organ? There's only one organ without that. Same thing with the lung. Where does referred pain from the lung go?
Sympathetics.
Well, the sympathetics are involved in respiration. What surrounds the lung? Pleura. You have your visceral, parietal, pleura. What's in your pleura? No. The pleura itself. I got that ready for you, so you're gonna study.
Oh, really?
Yeah. You're gonna study all about articular neurology.
Oh, sweet.
You have stretch receptors. You have stretch receptors in these pleura. So when that pleura stretches, the stretch receptor is facilitated and it's innervated by different areas of the spine, and you get referred pain back to that area. It's visceral somatic reflex. You feel pain from viscera in the body. Viscera, somatic. What does the pancreas refer to? Usually.
Usually just the back.
Just the back. Yeah, just the back. And the reason for that is only retroperitoneal obstruction.
What kind of pain would that be?
Just deep pain in the back. And they may have associated with that some other digestive systems, because the pancreas can also be involved with digestive, it doesn't release. What enzymes do you check for?
Lipase, amylase.
Amylase, lipase, elevated levels.
Yeah.
Doing good.
We'll see.
Our score is getting higher and higher.
Yeah.
Good shot.
One knockout punch.
None of these questions will be on it. It'll be something.
She really has.
Okay, next we'll start doing our lower extremity examination. Bring this leg down. We're going to do our straight leg raise. Again, while we're doing our
Just say she wasn't surprised.
straight leg raise, looking for radiation of pain. Okay. At the same time, we're also, at any time we're testing muscles or putting joints through motions, we're also checking for integrity of muscle, tightness, how far kind of elasticity we have in the muscle, okay? So again, all these tests reproduce not just the test you're looking for, but see what else you're testing at the same time. So here's your long track sign. If there was some positive test there on this side, you might want to do a Braggart's test. So you just take it and quick dorsiflexion of the ankle, same thing on this side, okay? You can ask the patient to actively raise it to see if it reproduces any type of back pain, whether going up or coming down. It could be an indication of maybe some lumbar or SI joint instability. And from here, again, you can check your hip flexors again. You can check quadricep strength. Bring the knee, the heel all the way down to your buttock. And you can check flexibility in the quads. Push up against knee. Again, you're checking muscle strength, so you can do that on both sides. Then you can do your test. Where'd you go, Patrick? Patrick what? Patrick Levere. Do you have pain in the anterior hip? What does it mean? So hip joint pathology, maybe sometimes you can get more specific. Sometimes it's an indication of femoral acetabular impingement if you have anterior hip pain. If you have posterior hip pain, which is there. That's actually a little painful. Where? Anterior hip? Could be like this is the adductus too, pointing right there. And again, if they have pain, where is the pain? Sometimes it's posterior, it's SI joint. And it is sometimes in some of the write-ups with Laszlo's protocol, they put in Gainsland's test sometimes, as well as the Faber-Patrick test. So then you do have your Laszlo's, so you have flat thrust. You do that on both sides. And then you have iliac compression, and you have iliac distraction.
There you go. I was about to ding you a point for not crossing the arms.
Then the patient has lateral hip pain, yes, they turn on their side. And you can check against resistance, see if it reproduces any pain either in the glute med, TFL, or long iliotibial bands. So push up, up, all the way, all the way, all the way, all the way, all the way. And hold it up there, hold it up, hold it up, hold it up, hold it up, hold it, hold it, hold it. See if it reproduces any pain. Glute med, TFL, iliotibial band, okay? For some adductor issue, if they have pain on the inner thigh, push down, push down, push down. And again, you also muscle test that. Okay? In this position, you can also do tests for piriformis. What is that called? Not the deer. It's got to do that before. Piriformis test? What? Just come right to the edge of the table on the side. Fair test.
Fair. Flexion, adduction, internal rotation.
Adduction, internal rotation. You get pain right in the buttock. Piriformis syndrome. We've seen a lot of patients with piriformis syndrome. Again, you can do this on both sides. Then for the rest of your Laszlo's protocol, you could do a Gainsland's test. Let's do Gainsland's and rotating your back. Just come to the side of the table. Bring this knee up to your chest. Hold it there. Let this leg drop off the table. Stabilize here. Push down. Any pain anywhere? The anterior part of the leg or in the back. Okay. And you would do the other side for the other SI joint. Now, what else do we have in this position?
Sacral thrust.
Sacral thrust. We would turn them over. We would do once you do Faber test. Faber test, glute med tendinopathy, an important test. Flexion, adduction, internal rotation of the hip. See if it reduces any pain in the hip. What's a good test for the glute med tendinopathy?
Single leg stands.
Single leg stands. Great test. Probably you've never learned it. No, you never learned it. And its accuracy and its correlation with MRI.
Oh my God, it's like 98%.
Yeah, 98% correlation MRI for glute med tendinopathy.
I did my CAW on it.
CAW. Very simple test to do. You're gonna have the patient just hold on to a wall if they can with single finger. You don't want them pushing into the wall. You may have to help them with their balance. Gonna stabilize this leg that's near the wall, which means this is what? Did it wrong. Testing the leg away from the wall.
Mm-hmm.
You're just gonna have to lift the opposite leg just a few inches off the ground. and just have them stand there for about 30 seconds. If they have glute med issue and tightness or definite tendinopathy, like I do, within a few seconds or 15, 20 seconds, it begins to hurt in that glute med, and they'll get reproduction of symptoms. You may feel it even going around to the buttock and down to the leg. You're not gonna be able to stand there and hold it. You would just, again, compare both sides.
First
It's a
5
very-
seconds is a grade 1. 6 to 20 is a grade 2, and then 20 to 30 is a grade 3.
So it is a very, very good diagnostic test for glute med tendinopathy. And then you diagnose it, you don't need to send out for an MRI.
And if you add in the Faber and Fadir, but you add resistance into it as well.
And again, your probability goes even higher.
Yeah.
So again, that's a test you do as part of the normal standing examination. You examine the patient if you haven't done yet. I know we're gonna get to it, but it's getting ready to. So I think we're finished with everything else here. So let's stand up real quick. And we're gonna have the patient, we're gonna observe their posture. You're gonna look for signs, just face that wall real quick. You're gonna look for signs of upper cross, lower cross syndrome. You should all know what they are. If not, we should send you all a couple of papers, okay? Then you're gonna do your lumbar ranges of motion. And you're gonna ask the patient, again, the patient should have their spine exposed. when you do these ranges of motion. You should be looking, especially if it's a young adult, especially if they haven't reached the age of bone maturation, looking for scoliosis. So they need to have their back exposed. You don't have them bend forward, and as they go forward, you want to look to see if there's any abnormal movement patterns as they go forward. Is the spine nice and rounded? Then come back up. And again, even with lateral bending, as they bend to one side or the other, slide that hand down. You want to see if that lumbar and thoracolumbar spine has a nice curve, and whether or not there's a sudden break, or is it a nice smooth curve, or does it just suddenly come over and then break? And that could indicate definite joint restriction. Then you do your rotation, you do your lateral bending, rotation to either side. You've pretty done, now done all your range of motion. Prior to that, the patient, if you suspected during your history any possibility of some kind of instability, during your history, you're going to ask questions related to, if you get up out of a chair, does your back feel like it's going to give out? You might say that. If you go to lean forward to pick something up, does it feel as if your back is going to pop or catch? Yeah. Do you have difficulty bending forward? Yeah, I don't want to do that. They have what's called apprehension. They do not want to go forward. They just think as they do that, it'll come back up, and it's probably happened to them, and that's why they don't want to do it. The back could potentially lock up. That is 3 positive findings for instability. If they had instability, then when you had them prone, just turn real quick. And with just the feet hanging off the table a little bit, no, just feet. You had some tests that you did, right? For instability?
Yes, sir.
This is the prone, leg extension instability. What you do is just keeping the knees straight. You just lift the legs up off the back, off the table, about 30 centimeters, and see if that recreates any type of low back pain. There are other tests that you can do. You can ask the patient to do it actively, and they lift the leg. Good. And if they had pain, what you might want to do is to either side of the spinous, press in, lift the leg up, see if that creates pain or reduces the pain. Because what you've done now is you've manually begun to stabilize that segment. So just as if those muscles were nice and strong again, you've manually stabilized that, and it could reduce the pain for them. And again, an indication of lumbar instability. Again, you've watched the patient, you've looked at their gait as they came in, you do your delay test, turn around, face the wall. I know you don't learn this in class. Oh, the delay test is horrible, the worst thing in the world. I always ask, okay, how do you determine where you're going to adjust for that side leg? If it's a restriction, how do you assess for restriction?
Usually,
Pelvic joint sprain.
I'll-
Okay, what are you feeling?
I think this test is good.
Spring. Spring? You got how many millimeters of movement or centimeters of movement from the inside leg?
Probably like 1, 2, or 3.
2 or 3. So it's hard to assess. So, yeah, there was a person, and he's still very active. He's done nothing but SI joint research. Cooperstein is his name. More articles published probably on, and more articles on the delay test. He presented a few different times at various ACC presentations. And we had a student here who actually went to Palmer West, where he was a faculty member. And he had him for a lecture, and he went through the whole SI joint, and he goes, I know, guys, he goes, I know I've told you all the delay test is not really good, but I do know this. Because I'm not ready to give up on the delay test. Because I think I have a lot of knowledge about it, but I'm not ready to throw it out at all. I think to me, it still gives you some information. SI joint is a complicated, very complicated joint. The referral patterns from the SI joint mimic disc herniations, facet joint changes, facetogenic type pain, sclerotogenous type pain. And I used to have in my office down here the pain diagram for the SI joint. Hopefully I can find it in one of those boxes. But it could be everywhere. It could be just right over the buttock. It could go down the posterior leg. It could go over the lateral part of the leg. Could even come down part of the anterior part of the leg. One other test I forgot in this position. You can just lie down again real quick. Sorry guys. On your stomach. And again, another important test. Because again, this condition Mylin knows all about. Veins. You do your femoral nerve stretch. So again, femoral nerve is entrapped here. T12, L1 segment.
I didn't say Williams. Oops.
It'll reproduce anterior pain, but it will also reproduce anterior quad pain, or pain where the tendon attaches, the quad tendon, and or psoas pain. So it's a good test again to do. And then you also have your internal, external rotation. Piriformis stretch test. Again, you're stretching the piriformis muscle against internal and external rotation. Okay. And then just do one other thing for the modified Thomas before we go into these other tests. Modified Thomas, at some point in your exam, incorporate it, whether it's on your initial, if it's just low back. First thing you want to do, have the patient get to the end of the table, be a patient for them. Okay? Then, ask them to bring this leg up to their shoulder. Don't touch them. Observe first. As soon as you touch a patient, remember, you are a sensory being. You react quickly to sensation many, many times. You start touching a patient, doing this, they will begin to change or suddenly move their body. So get them down, head down, need to put a pillow underneath it, and then look. Is there tightness? Is this leg coming up showing potential psoas? Is the knee extended too far? Okay, showing again tightness. If you do this, does that recreate any pain in the quad or the quad tendon? If you press down, does that give them any pain in the psoas? Also looking to see, is the leg abducted or adducted? Again, contraction of adductor muscles, adductor muscles. Then you do the same thing on the other side. Again, let the patient just stay there, relax, look. See, this leg actually elevates a little bit on the left side. And again, you would test the same thing. Any pain or discomfort in the psoas. And then this position here, the modified Thomas, is also a good position to actually stretch these muscles in these positions. So you could do a PIR stretch, you push up, and then relax. And you can stretch out, and you can even do the quad, same thing. Push out, and relax. So you can do both testing and therapy same time when you have the finding.
Would you be able to cut corners and maybe do all that while you're doing Gainslands too?
Yeah.
Yeah? Okay.
Yep. Again, some of these you may not incorporate into your initial examination, but follow-up visit. Say, gee, I got a lumbar spine problem here. I'm going to do some other additional testing. I might do my modified Thomas. I might do some other testing. You're going to incorporate your delay test. So let's just do the delay test. But there's two parts to this. Delay test, stork test. Your delay is your typical, you're going to have one finger or thumb on the PSIS on the right, over the second tubercle. They lift up their right leg, right leg, right leg, right leg. And you're going to look to see if your right finger, right thumb drops. Indication of movement in that SI joint. Switch to the opposite SI joint, same thing. PSIS, left thumb, sacrotubical right thumb, lift the leg up, that left thumb should drop. Now, with SI joint instability, again, Gillette test set up, left thumb, second sacrotubical, right thumb there, lift your left leg just a few inches off the floor. And now you're gonna see how that right thumb moves. As it moves up, it could indicate potential SI joint instability. These are the patients who'll have chronic SI joint pain. These are patients who'll be seeing chiropractors and they adjust the SI, adjust the SI, adjust the SI. Doesn't get better. These are the patients who are building up some inflammation. You're getting buttock pain, you're getting the posterior leg pain, you're suffering, oh my God, disc. Not disc, could be SI joint instability. The treatment is stay away from the SI, look at the rest of the lumbar spine, strengthen, stretch those muscles that need to be strengthened and stretched. And then there are other tests you can go into more detail, begin to observe for that. Another test that can be done, again, you have your Trendelenburg, you would do Trendelenburg, looking for hip drop and signs of potential, again, weakness in the glute medius muscle. And then you also have single leg squat. Just come down, see if you can just bend down just a little bit. Oops. That's, we'll go down a little slower.
Go down a little slower?
Yep. And what you're gonna look for is see if that knee, you don't have to go that far down, you don't have the patient.
No, stay down there.
And what you're really looking for is seeing if that knee deviates medially.
Keep doing it till something pops.
Potential weakness in that vastus medialis, see potential weakness in that glute med, they're losing stability in and around that hip joint. So, I think that was a lot, there's probably a few other little things to cover, but we'll stop there. Okay, so an idea now of how to get through the examination a little bit. Now it's just a matter of going back, practicing, and putting together your own physical exam.